Right. Thank you everyone for joining us. I know we just had a wonderful conversation in our last session, was really exciting. I am so excited to be here today with Rachel Antonini, talking about a glimpse beyond the airway, breathing, and circulation. Thank you so much, Rachel, for being here with us this afternoon. I will go ahead and pass it off to you.
Thank you. Hi, everyone. Thank you so much for your attention. Um, and just as was mentioned, I will be speaking about endotracheal tube management, less invasive respiratory support strategies, and umbilical line securement considerations. So first of all, I'd like to talk to you about endotracheal tube management. As you can see here, this baby is intubated. You can see the tube going in the mouth there. The baby appears to have a dressing on its abdomen and is an IUGR 26 weeker. So, indications for endotracheal tube intubation would be prolonged positive pressure ventilation or respiratory failure, diagnostic indications such as diaphragmatic hernia, gastroschisis, cardiovascular emergencies, etc., critical upper airway obstruction, and obviously pre and post-operative respiratory support. Anytime you consider a medical procedure for a baby, you also have to consider what potential complications might arise. In the process of intubating, a baby can have cardiorespiratory instability during this intubation attempts, or sometimes require more than one. Additionally, the baby can be intubated into the right mainstem bronchus. And what that means is if the tube is advanced a little bit too far, it typically would go off to the right side and be too deep. The significance of that is that then you're only ventilating one lung, and not only are you applying excess pressure on one side of the lung, but then the opposite side can collapse. Additional considerations would be an accidental extubation. You can have blood return from the endotracheal tube. That could be from a pulmonary hemorrhage or from trauma associated with the actual procedure. You can have excess secretions that are preventing visualization of the cords. This is why sometimes people suction, but suctioning in and of itself can cause the baby's heart rate to drop, cause them to vagal, etc. So you want to remove secretion if needed, but not just make it a habit. Additionally, the vocal cords could be closed. So perhaps the intubator has perfect visualization of where the endotracheal tube needs to be passed, but the cords can actually be closed. Finally, you can have an inability to pass a tube between the vocal cords. So this could be from an endotracheal tube that is too large. And additionally, it could be some kind of anatomical issue, such as the tracheal web, that prevents the intubator from actually being able to advance that tube. So when I talk about the last thing, which is the inability to pass the tube through the vocal cords, I think we also need to then discuss the NRP guideline for endotracheal tube sizes. So I'm sure everybody knows, but NRP is the neonatal resuscitation uh, protocol in which we utilize, or we basically determine the guideline by which providers learn how to take the initial steps of resuscitation. And then it provides a guideline for certain things such as line placement and obviously endotracheal tube sizes based on a baby's birth weight and a rough estimate of their gestational age. I'll be honest, typically we look more for the size of the baby as opposed to the gestational age. At least that's been my practice. And I also want to recognize that in this little diagram here, the smallest size I mentioned is a 2.5 millimeter endotracheal tube. There is a 2.0 endotracheal tube size, and that some institutions might utilize that. It is difficult to suction because the indwelling suction catheter doesn't pass through that, and so that's kind of the standard is to go down to 2.5. Additionally, I want to mention that if you have an IUGR baby, at times, while the size of the baby might be, maybe it's a 1 kilogram baby, but 26 weeks, that sometimes the anatomic interior or the trachea might be slightly larger. So you want to have some consideration for gestational age as well, and kind of go from there. So some people might know that I used to be a math major. I love math, and I think what I love about math is the ability to use physics to make sense of our world. So the importance of identifying the appropriate tube size when intubating a baby really falls down to Potpourri's law. And so this law discusses that the rate of flow is proportional to the radius of the tube to the force power. So what does that mean? It means a small change in the internal diameter of the tube has a significant effect on flow rate. Therefore, if you think about what that means for a baby, is that if you put a tube into or between the vocal cord and it's too small, it's almost like you might think about trying to breathe through a straw. We're used to breathing through our adult-sized trachea, and so if you make that diameter much smaller, it has a significant impact on the rate of which we're able to breathe in and breathe out. And so that is why it's very important to select the largest tube that's appropriate for the patient. So oftentimes the intubator will be asked to visualize the cord and have a rough estimate of the size of tube that would pass. And you might say, did the tube, you go to advance the tube and you realize that it's going to be a tight fit. Or you might say the tube passed easily, we might need to upsize it. We also have the ability to have feedback from the ventilator after we intubate, and that feedback is what we look at in terms of the leak around the endotracheal tube. So that brings me to the next point. It is standard practice to use an uncuffed tube in the neonatal population. And the reason for that is because in children, the airway just below the vocal cords, called cricoid cartilage, is the most narrow part of the airway. This is different than it is in the adult population. So that's why we don't want to simply put in a cuffed tube and expand it full of air and then subsequently potentially cause tracheal damage. Even though that might be an easy way to address a baby whose anatomy was larger than expected and you have the large leak. It's actually better to upsize the tube to for a better fit as opposed to using that cuffed tube. So how do we know where to place it? So you've identified that the baby needs to be intubated, and then you've advanced the tube, but how do we know actually when it's in the right place? Obviously, when looking at an airway, you see two holes, one being the esophagus and one being the trachea. And oftentimes people, when they are learning to intubate, they get really excited when they see the first big gaping hole, and they put the tube down, and guess what? You see gastric distension, and you ask the intubator, where's the tube at? They say 15, and you realize as the person teaching them that perhaps that's not in the right place. And so what do we do to help us identify if the tube is in the right place? Well, we have something called a pedicap, and this little device responds to exhaled CO2. I'm sure most of you have seen it. It came about I've been in neonatology for 20 years, and I remember when it first came out, and it was really cool to think about this little device that attaches between the endotracheal tube and the handbag mask, and it actually changes from purple to yellow, back and forth, when you see that CO2 exchange. Additionally, you want to look for equal and bilateral breath sounds. So that also goes back to what I mentioned earlier, that if you advance the tube too deep, it can go into the right mainstem bronchus. So that might be a situation where you hear breath sounds much louder on the right side and very minimally or diminished on the left side. We also want to look for chest rise, and we want to see minimal or no gastric distension. Now, I do want to mention that sometimes on a very tiny baby, you might be listening over the stomach area, and you might say, I hear breath sounds. Well, in a very small baby, you might hear radiation of that, of the breath sounds into that gastric area, and that's just because they're so small. And so that's when it's really important to also listen to the breath sound over the chest area. And then you might say, oh, wait a minute, I'm actually hearing them well in the chest area, and I'm seeing the chest rise. Additionally, we specifically want to look for a rising heart rate. That's a key component to NRP, that when you have a baby that is intubated, that you see a response from the heart rate. And then additionally, condensation visualized in the endotracheal tube. So when you think about NRP, then the resuscitation guideline by which providers are, going through the steps of resuscitating a baby, these are some of the key things that the intubators should verbalize in that position, saying, not only I watched the endotracheal tube pass through the cord, somebody else might be listening saying, I see chest rise. The person intubating is going to say, I see condensation in the endotracheal tube, and then the lead will notice that the heart rate is rising. All key indicators for optimal placement. So now we've got the baby that is intubated. We have a rising heart rate. We've got chest rise, and we've got condensation in the tube. Now we have to manage it. It's very important that the intubator hold the tube until it's otherwise secured. I have seen, whether it's in simulation situations or real life situations, but nobody wants to successfully intubate a baby and then watch the tube get lost in the process of continuing to resuscitate, or in the process of attempting to get it secured. So a goal is to prevent accidental extubation and maintain that secured airway. And so communication is key. First of all, we want to estimate the position based on the baby's weight. Many of you may have heard of the +6 rule, which means that if you have an estimated baby weight, you add 6, and that's the location by which you want to secure the tube. For instance, if you have a 3-kilogram baby, you're going to add 6, and you're going to secure the tube at 9. Once this tube is secured, you want to then verify the position with a chest radiograph. So in obtaining the chest radiograph, you want to notice that the endotracheal tube lies somewhere below the clavicles and above the carina. Obviously, the carina would, if it's sitting at the carina, would be too deep. This typically falls between T2 and T4 on the X-ray. Additionally, you want to note the head position and the bevel direction of the endotracheal tube. You'll actually be able to see the bevel direction on the X-ray. And specifically, if the endotracheal tube is on the posterior tracheal wall, you do have a risk of obstruction. However, if you've ever looked very closely at an endotracheal tube, which I'm sure most of you have, there's something called a Murphy's eye, and this is actually something that should prevent that complete tube obstruction. If you notice that the bevel does not, or if you're not able to see the bevel direction, it does not mean you have to re-intubate the baby, but potentially you could just twist it slightly and re-secure it to ensure that the tube and tip is in an optimal position. So when all things do not go as planned, we have something called an unplanned extubation, which is considered one of the most common adverse events during mechanical ventilation. The significance of an unplanned extubation is that it can lead to longer duration of intubation in general, higher incidence of bronchopulmonary dysplasia, longer hospitalization, and subsequently increased costs not only for the family, but for the institution, and additional risk of complications, etc. And so obviously our goal is to decrease unplanned extubation, because that would then lead to significant cost savings for hospital systems, cost savings for families, and obviously our goal is to get baby home with family sooner, or as soon as possible. So this is why I'd like to talk to you about securement options. So in this picture, you'll see a baby. This is obviously not a real baby, but you will notice that the endotracheal tube is taped. You'll also notice that there's a little tab right here, and that's called a safety tab, whereby somebody could loosen the tape or unwrap the tape if they need to make adjustments in the endotracheal tube. So currently, this is a standard at the hospital I'm at, Lucille Packard Children's Hospital, and 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 the reason for that is just a matter of what seems to be working the best for us, and there is some degree of institutional practice, and then part of that is because proficiency is key. You want to make sure that you have um, a consistent taping practice, that you have a team of people that are trained in how to do it, because as you would see in this picture, the tape is kind of cut around the nose. You want to make sure that you have a process by which you can also secure the OG tube. Most babies that are intubated have an OG tube, and that you have a team available during the retaping or adjustment time, because um, if the tube is loosened or becomes soiled around the area, maybe the baby has an emesis or whatnot, that you have a reason or a guideline or a protocol to provide some direction to the team as far as how to manage that and when retaping is necessary, and a way in which, or a process in which it is followed when it needs to be adjusted. We have a team identified when we do retape. For instance, we have somebody that can intubate, needs to be a provider. We have people identified who are holding the tube, somebody identified who is retaping the tube. And we actually have a check-off list to make sure those appropriate team members are present. Again, the goal being to prevent unplanned extubations. Another securement option that was actually in that picture of the baby I showed you earlier is something called a neobar. So the neobar has a lot of different sizes. I think there's 10, and in my experience, I feel like it can be difficult to size correctly. Specifically because, we've all seen the baby with chubby cheeks, and, maybe a little bit of wiggling. Um, you know, does that movement have a potential extubation risk? Obviously, I think there's some variation in terms of your own institution and what works best for you and your team, and their own practice policies. And education is important, whether it's a handoff of measuring it shift to shift to make sure the baby gets bigger, that it's resized. Um, but something that I do think is really nice about the neobar is, if you have any kind of craniofacial abnormalities like a cleft lip, the neobar actually is very usable in that situation. And then if you'll notice, there's no tape on the actual baby's lip area. And so looking at skin integrity, that would be a consideration. And then additionally, you can also then tape the OG tube to that little tab that is where the endotracheal tube is secured. Additionally, the visualization of the marks on the tube, I think, is perhaps a little bit better than in the taped situation. So that would bring up a point that when you're taping, or if you're using tape, that the RTs could then, or would need to measure to verify that position, depending upon where it's taped and where the number they're marked on the tube, just to make sure that the appropriate position is consistently documented. So moving right along, an additional product that I more recently became aware of is something called the Archangel. And I'll be completely honest, I have not seen this utilized in practice, but I do find it a little bit intriguing, and I wanted to discuss it for this. Is it's a way to secure both the OG, or it looks like an NG tube in this picture, and also the endotracheal tube. I did learn it was developed by a nurse practitioner, so I thought that was kind of fun. Obviously, I'm a nurse practitioner. But again, this one does not have any tape, so I felt like it's in a way similar to the neobar. The little tabs actually click right into the cheek pads, and so if you're needing to remove the tube, it actually disconnects right there. I think you push a button here and can pull it out. And then from their website, they mention that there's 5 different sizes. They advertise no tape, and that it's MRI safe. So I thought this product was interesting. I have not been able to do much research on it specifically, but definitely an interesting interface. Moving right along, another product that I've seen, but again, not personally used, is something called the NeoFit. They advertise that it's a one size fits all. Again, a direction to say no need for tape on the endotracheal tube. And they advertise about the markings being easily seen. My own personal bias might be that if there's no tape, I have the history of being a nurse. Nurses, I think, love to tape, and so, if you don't have any tape, I don't know. I would be concerned perhaps about a potential extubation risk. So I'd be curious if people have used this product, if they have any input about that. So again, just a mention for products out there. So moving right along, I'd like to go on to my next topic, which is a discussion on some respiratory support strategies. So obviously respiratory support is a continuum of care. Things that we look at would include vital signs such as temperature, heart rate rhythm, effort, blood pressure if it's available. Obviously in a resuscitation area, we're not typically taking the blood pressure, but we're going to look at things like color, oxygen saturation, oxygen supplementation if it's needed, and the baby's kind of overall appearance. So I would like to make a list and say, so these are kind of the thing that we're focused on in an overall assessment of their respiratory status. So work of breathing, do we have a chest x-ray available? Do we have a blood gas available? And then obviously, the full assessment of what's going on from a respiratory effort perspective. So why is this important? Well, anytime a baby is in respiratory distress, it can progress. Baby might start out in mild respiratory distress, where you have maybe a rapid respiratory rate without signs of additional distress, may or may not need supplemental oxygen, but that can actually quickly progress. And so at that point, they become cyanotic in Vermeer. Suddenly they're grunting, they're having retractions, maybe some nasal flaring. And so, you want to intervene because, things can change very quickly to severe respiratory distress. And this is when the baby is hitting a point of exhaustion. Maybe they're unable to maintain their SpO2 above 90%. Obviously, with the caveat, if it's a cardiac baby, we're looking at something different, and a premature baby or saturation, percent would be adjusted appropriately for their age. But the point is that we want them to maintain a normal saturation for their gestational age or clinical status without the supplemental oxygen that would otherwise be needed when they're progressing into that triad or down the road of increasing respiratory distress. Additionally, you might see a baby that has an altered neurological status or exam. So this baby might become hypotonic or have decreased response to stimulation. It's when the nurse says, we placed an IV and he didn't even respond. I checked a blood gas, I did an ART stick, and he's been fighting me all day and cranky all day or feisty all day, and now nothing. And so that's something that, as the provider or the medical team should really be paying attention to those changes in their physical assessment, in their physical exam. And then obviously, neonatal environments, we love numbers, we love to pay attention to things like blood gas value. And so that oftentimes as you're progressing in terms of severity of respiratory distress, those values will become more and more abnormal. So the point is that we want to be constant and we want to be aware. Infants may progress from mild to severe respiratory distress very quickly. It's important to provide the support that's needed before they progress to a point where you do have to intubate them. This picture I also want to point out, in a resuscitation, you've got a lot of people involved. You have, in this picture, somebody doing chest compression, you've got somebody listening, somebody providing PPV, somebody else holding the endotracheal tube. And the point is that we, obviously we want to be able to resuscitate when necessary, but we don't want to get to this point where baby is needing chest compressions. We want to be able to be aware of some of the earlier signs of impending respiratory distress, outside of obviously, an acute decompensation post-birth. But the point is that you really want to provide the support needed, um, a little bit ahead of time, not to the point where you're trying to play catch up. So, obviously a normal respiratory rate is 40 to 60 breaths per minute. I think that's pretty much universally accepted. And so, if a baby's having tachypnea or fast breathing, or slow breathing, these could both, be a sign of exhaustion or impending exhaustion. It can also be a sign of brain injury. So you might see really slow breathing from HIV or HIE or IVH, cerebral edema. Additionally, metabolic disorders when you've got a high ammonia level, opioid shock, neuromuscular disease, or you might have a baby that's gasping, and obviously, gasping is not respiratory effort. That's good. Gasping is a sign of impending cardiorespiratory arrest. Now, that's not to say that every baby breathing 75 needs to be acutely, jumped on to intervene. I think most of us have probably seen, that happy tachypnic baby who has a comfortable work of breathing. This is really where it comes down to an assessment, right? You want to look at all these things that I've mentioned, vital signs, stability, changes, etc., to make sure that we're paying attention to all of these different stats. In looking at increased work of breathing, babies might do things like nasal flaring, grunting, retractions. Quick review: suprasternal is above the sternum, subcostal is under the rib cage, substernal is right below the sternum, and intercostal being between the ribs. Now, the premature babies, I feel like oftentimes, because they have no brown fat, it might be more or retraction might be more easily visualized, even though they're not necessarily having increased work of breathing. So that's where, again, it falls down back on your assessment skills and your awareness of kind of the baby's overall clinical picture, that just because a micropreemie has intercostal retractions does not mean they necessarily need an escalation of respiratory support, but rather a point that these are the things to be evaluating and to be considering when looking at a baby that is potentially having an increased work of breathing. The reason why is because this increased work of breathing is one of the first signs of air hunger, and it's baby's attempt, going back to Potpourri's law, as far as the airway diameter. Like, the baby is trying to increase that airway diameter because then it makes air flow more easily. So yeah, back to physics. But what they will do is they will increase that airway diameter by flaring the nostrils, and so that's where we see that nasal flaring. Some of the causes: airway obstruction. You might see this in bronchiolitis, croup, acute epiglottitis, pneumonia, acute asthma in like the older child or older infant, or TTN, transient tachypnea of the newborn. Grunting is when a baby attempts to increase that functional residual capacity because the alveoli are collapsing. So vocal cords will partially close to trap that air in the lungs, and it's a mechanism to improve that oxygenation and ventilation until the baby gets too tired. Typically, grunting begins pretty quickly after birth, maybe even in the delivery room, and usually will resolve within a few hours. So this might be the baby that needs a few hours of CPAP. That being said, if it doesn't get better in a few hours, or if the baby is older than a few hours and then it starts grunting, it might definitely where further evaluation is warranted. So progression of distress would then be when we see retractions, and go from there. So we want to, back to one thing I did want to mention is when we're looking at this functional residual capacity, when we're looking at grunting, I always try to explain to parents what's going on, because I've had dads say like, "Oh, my son's really breathing like a real man because he's making that grunting sound," and to just try to explain to parents and to make sure that when we are assessing these, increasing respiratory distress, that we're being fully transparent to parents as far as they're concerned and to involve them in our assessments as time goes on. Because you never want to be in that position where um, you've progressed to the point of needing intubation and you've been watching this baby for a few hours and parents think everything is going along just fine. So what can we do, or other ways to gather data? Non-invasive monitoring would be looking at that saturation. So the percentage of hemoglobin that's carrying oxygen, and pulse oximetry is something that is an estimation of O2 saturation. So preductal saturation is measured on the right hand or right wrist, and it's usually the preferred method during the initial resuscitation. Additionally, we can use something called near-infrared spectroscopy. And so this is actually a measurement of regional tissue oxygenation. It's a little probe that goes in the forehead and over the kidneys. And then it's looking at more of an extraction. So usually we look at renal and cerebral, and you can see some normal near values there. And so this is, again, use in addition to a saturation monitor by which we can have a non-invasive method of monitoring kind of the baby stability and progression. So for instance, if you start having lower NIRS values, that could be also in support of needing to provide some extra intervention. So specifically, when it comes to NIRS values, we want to consider a cerebral saturation, or our goal is to have a cerebral saturation definitely above 50%. Reason for that is because numbers under 50% have been shown to affect your long-term neurodevelopmental outcomes. And so that's kind of the marker that we use consistently for when to intervene. And so questions to ask yourself: is the infant hypoxic? So that goes back to your saturation. Is the baby hypotensive? We've talked about checking blood pressure. Is the baby anemic? Maybe they need a blood transfusion to improve that oxygen carrying capacity. Is the infant hypocarbic? Do we need to optimize our respiratory support strategies to better support them? Additionally, you might look at ways to reduce their cerebral metabolic rate. Maybe they need sedation. Maybe, it's a pulmonary hypertension baby that is not able to adequately oxygenate in a good way. And so you really want to keep those babies super calm. And then for cardiac patients, you want to ask yourself, do these values correlate with other indicators of poor systemic perfusion, things like urine output, maybe a lactate level that's elevated, how their extremities feel, and really just intervention that would improve that QPQS, such as your PEEP, increased hematocrit, maybe your PG dosing if it's a cardiac baby, and then obviously like a consideration for earlier surgical intervention. So in terms of what we do with this and looking at, ventilation, respiratory support strategies, three things that I wanted to talk about: CPAP, PPV, and endotracheal tube intubation. So what does CPAP do? It's continuous positive airway pressure. It improves lung inflation, prevents collapsing of alveoli. So that sounds pretty simple, right? But as I mentioned, it's important to explain to parents what we're doing, why is this being provided. And I want to mention that when I mention CPAP, I want to include those modes of ventilation or respiratory support that provide a CPAP effect. So that would include things like high flow nasal cannula, maybe the ROM cannula. We don't use that at Packard, but I've used it in the past at other institutions. And so any of these things that provide that CPAP effect would fall into this category. So what does CPAP do? CPAP is something that prevents those alveoli from collapsing. So when I tell parents and when I talk to families, when I'm teaching a new NICU nurse, I say, imagine blowing up a balloon. And the first time you get a balloon, it's really, really hard to blow it up. But once you get a little bit of air in that balloon, then suddenly it becomes much easier. Like work of breathing improves. And so what CPAP does is it prevents that balloon from completely flattening. And thereby it effectively improves or decreases that work of breathing. And so that's kind of what we mean when we say that it prevents the collapsing of alveoli. PPV, positive pressure ventilation. So that is basically a way to have a set PIP and a set PEEP, so positive peak inspiratory pressure and positive end expiratory pressure, and you set those numbers. So it's more precise in handbagging, and it's a way for us to provide ventilation to a baby that might ultimately need to be intubated, or perhaps they're just in secondary apnea and need to be brought out of that. And the thing that you want to look for is chest rise, and again, that increasing heart rate. So PPV is one of the most difficult skills to learn. I think many people take it for granted. Many people, assume other people know how to do it, but I think it's really important to have good hand position, really important to have a good mask seal, and really value the significance of being a really strong in that step of NRP, because effective ventilation through PPV can make a huge difference in having to take or not having to take that next step in terms of endotracheal tube intubation. So, final step of the and the slide as far as assisted ventilation would be that endotracheal tube intubation and subsequent vent support. So if you've been providing good PPV, you have good chest rise, you have a rising heart rate, but you still have a baby that is not breathing on their own. So apnea, continues to have labored breathing. You need that escalation of support, or maybe there's an anatomical indication that require intubation immediately. For instance, a baby with gastroschisis, and you don't want the GI tract to fill full of air, diaphragmatic hernia. Again, you want to, identify those anatomical conditions that would have an indication for immediate or urgent endotracheal tube intubation, in addition to those babies for which they would need that. It's a matter of intubating as a mode of, in the setting of escalation and support that's indicated by the baby. Additionally, I wanted to mention both LISA and SALSA. These are both modalities by which we can administer surfactant. So traditionally or historically, in order to administer surfactant, you would have to intubate the baby to then give them surfactant and then work towards extubating them at a later time. So at LPCH, we launched, back in December, we launched the ability, or we basically, taught all the providers and whatnot how to both administer or both LISA and SALSA. So LISA stands for less invasive surfactant administration, and then SALSA stands for surfactant administration through laryngeal or supraglottic airways. And so what this does is it basically enabled us to administer surfactant into the trachea without then intubating the baby, which once you intubate the baby, then they're on a ventilator and they have to be weaned off the ventilator, etc. And then additionally, just an important factor that it combines this surfactant delivery and spontaneous breathing with that support of non-invasive modes of ventilation. So something that's really cool. Really great to see, and it has been quite successful for the babies that for which it's indicated. Now, importantly, this mode of less invasive surfactant administration, or administering it through the laryngeal mask, the important thing is that this does not replace a baby, or does not replace a baby for whom intubation is needed. So if the baby is apneic, or the baby has an anatomical condition that requires intubation, or the baby has extreme work of breathing that might be treated with surfactant but has other things going on, you might still need to intubate for those other reasons. And so to recognize that one is treating surfactant deficiency and the other one is treating that work of breathing, apnea, etc., and going down that pathway. So obviously early treatment leads to better outcomes. So back to the little baby that I showed earlier in my slides, you've got a baby, tiny IUGR, significant pulmonary hypertension, with a nitric for many months, ultimately went home on oxygen. Here she's about 2. And then by the time she started kindergarten was off of oxygen and growing well, rambunctious and full of energy. So early treatment, appropriate treatment, optimal treatment obviously leads to the outcomes that we all like to see. Moving right along, I now like to talk about um, my final topic, which is umbilical line securement. Um, so umbilical lines are something that are very common in the NICU environment for our preterm babies and for cardiac babies, or very, very sick babies, etc. It's a way to obtain both venous and arterial access in a way that is, secure and a great way of monitoring blood pressure, etc. So we all can agree about umbilical lines and their indications, but I think it's also important to identify some key points for why umbilical line securement is important. So anytime a line migrates, that can lead to malposition. And malposition of an umbilical line, which is a central line, can cause complications. Obviously, it's important to minimize movement to prevent line loss and prevent those complications. As such, the provider should ensure the line is placed properly prior to final securement, and this is done through a combination of x-rays, making adjustments as needed, suturing, and then obviously finally securement. So when it comes to UACs and UVCs, the catheter is based on a baby's weight. So we have a 3.5 French or a 5 French. Additionally, the depth calculation that I learned many moons ago, 20 years ago, was it utilized the baby's birth weight. So you basically take 3 times the birth weight and add 9 for the UAC, and you divide that number by 2 and add 1 for the UVC. So if I lost anyone, let me give you an example. So imagine a 3-kilogram baby. So to calculate for the UAC, we're going to go 3 times the birth weight. 3 times 3 is 9, and we're going to add 9. So our depth calculation for the UAC would then be 18. We also want to place a UVC, so we're going to divide that 18 by 2. We have 9, and then add 1 for the UVC. So we have our depth calculation of 18 for the UAC and 10 for the UVC. When it comes to UVCs, they come in single, double, and triple lumens. At Lucille Packard, we use both single or double lumen, and then I've also used triple lumen catheters at other institutions. And so the significance of what lumens mean is that you can actually put in one line, but have dual ports. So what that means is you can have a TPN line, and then you can have the second lumen of the UVC, maybe be a med line, or you could give blood in that line. Triple lumens were great for cardiac patients, but again, all these, it's, what works best for your institution and your population, etc. I haven't done a lot of research about it, but the research that I have done did not show a significant change in infection risk from single, double, or triple, but it still came down to how long that line was in. So I thought that was pretty interesting. There might be a slight increased risk of lines clotting off if they're smaller, or if you don't have something infusing in it. Some institutions might lock lumen. Other institutions, if they have a history of those lines clotting off or wanting to maintain patency. And that's why it's important to think about what your patient needs, because if you're obviously needing to infuse through 2 lumens of a UVC, then you want to make sure that you're not having that extra lumen for no good reason. So other considerations might be, can you split TPN? And what I mean by that is once your baby is out of that initial phase of acute sickness, and now they're more stable and just feeding and growing, how can you optimize that nutrition for your micropreemie using that double lumen UVC? And so some institutions have the ability to infuse TPN through both lumens, so you're not just running a chaser fluid. UAC lumens are always single. And that's just a matter if we don't need 2 lumens, and the single lumen would enable you to monitor the blood pressure. Some institutions, if you only have a UAC, would allow for TPN administration through the UAC. So again, some aspect of institution specific, but a lot of research out there as far as that goes. And then just a point that UVC and UAC should be secured separately. So suture and tape bridge. This is a nice picture. I'd like to point out that here you've got the provider that is suturing the umbilical line there, and you see the umbilical tie around the stump of the umbilicus. And then you see this lovely tape bridge. I see the lines separated, and then obviously it's adjusted for the size of the baby. I do want to point out one concern I have for this picture is that the tape appears to be directly on the baby's abdomen, and obviously for skin integrity reasons, we would like to avoid that. So putting duoderm on the baby's abdomen and then putting the tape directly on the duoderm would be preferred. So regarding tape bridge, this is a skill that the nurses must learn, and obviously it can be difficult to make adjustments. So going back to this picture, you can imagine if I said, please pull out the UAC by 1 centimeter, it's a little bit difficult because you've got this great tape securing it exactly where it's at. Additionally, maybe there's a risk of cutting the catheter when cutting the tape away. I've seen lines nicked, cut entirely. And so it's really a matter of a lot of education. Obviously, tape has minimal institutional cost, and then obviously the size of the bridge tape is fully adaptable, meaning you can totally adjust the size, how high over the stump, and really make that a size specific to your patient. Another securement device is something that I have some familiarity with. We've used it at Packard in the past, and it's called the life bubble. And so this avoids tape on the abdomen. You see there's duoderm, and then the little wings are attached to that. And then each line is wrapped around the little knobs and hooked into place. And so this securement device, it protects the umbilical stump and still allows for that clear visualization of the catheter position. And then it also has the ability to reposition or remove the lines without putting adhesive on the actual catheter. Sometimes parents have reported maybe being a little bit more comfortable because the umbilicus, has this little cap on it. And then obviously there's 2 different sizes of this device, whether it's a small baby or a big baby. Something kind of cool point is it was designed by one of our Stanford biodesign fellows. So another device that's out there is called the Neo Bridge. I was not able to find a picture of this securement device on a real patient, but something I would like to point out is if you notice how flat the umbilical stump is in this doll. And so, in first acknowledgement, I'm going to say that doesn't look super realistic, and I think that's something that some institutions have run into. I know we've trialed this, and there was an issue with that cleared space above the umbilicus that Arns had some concerns. This had a micro, a small, and a large size. It is kind of interesting that they have these flaps are actually made to pull apart, so you could pull them apart, adjust your line, and then close them back. And obviously, being clear, it allows for good visibility, and then just a concern that there could be moisture and oil that could affect adhesion. And then finally, a fourth method that is, I feel like, somewhat common and out there is tegaderm. And so here you see a duoderm on the baby's belly that the catheter is kind of coiled around, secured with a steri strip, and then the tegaderm is put over it. And I would date myself, I think this is an older form, and that's just how I learned to secure lines. At first visualization, I thought this was kind of interesting. This picture showed that a steri strip is wrapped around the suture, and I thought that was kind of an interesting safety mechanism, because I think a concern of something that would occasionally happen, and if you notice that unlike the other 3 methods that I've discussed that kind of secure the line above the belly button in like a more vertical way, this being off to the side allows for potential migration out because the securement is actually on the side. So yeah, basically the line possibly less secure at that insertion side. I think it really relies heavily on the providers on that initial securement. And then I feel like it can also be a little bit difficult to adjust. So say if you cut the sutures to then pull the line out by ½ centimeter, if you're using tegaderm, it really needs to be sutured back into place, where the other securement methods wouldn't necessarily require that. And then the catheter markings can be a little bit more difficult to read accurately. You can see it's kind of coiled up under there. So you really have to be careful about tracing it back to make sure that your line is in where it's been documented at. Obviously, this again has another method that would have a minimal cost to the institution. And then just to mention that I feel like in an urgent or emergent situation, the tegaderm is a really nice way to quickly secure the line when you don't have time to make a pretty tape bridge or get some kind of securement device or tape flaps, etc. That you can really just slap that tegaderm down and keep that line in place to then allow you to either volume resuscitate or give blood. So just wrapping things up, I wanted to mention that, healthcare involves complex tasks, highly skilled and educated team members, diverse patients, and multifaceted interactions across the health system. And equitable care is important. We serve a diverse population of patients, so it's really important to personalize care, communicate with compassion, with being aware of language and cultural consideration. And should really have a family-centered approach, encouraging those conversations to keep your family involved so that they are aware of what's going on with a patient. Also important to identify potential barriers and to set expectations with a team approach by identifying your resources and being supportive. Build on your knowledge, optimize care, and model trust. These are a few of my references and resources, and I would be happy to take any questions.
Thank you so much, Rachel. That was a wonderful presentation. I'm sure everyone else enjoyed it as much as I did. Thank you again. We have a couple of questions that have come through so far. Anyone else, if you have any more, please feel free to put them in the chat. Our first question is about if you have any thoughts on the kind of available equipment that is being stocked in certain institutions versus what staff may feel like is either best practice or what preferred methods may be among staff members, and how to advocate for the equipment that we feel like is most functional and most appropriate for our patients.
Yeah, so I think it's really important to be aware of what your institution has available. So for instance, if you don't have a ventilator, for instance, and then it maybe is, you can intubate a baby, but you don't have a ventilator to put that baby, you're still going to need somebody to be able to provide that PPV. You can still do it through the endotracheal tube, which would be more secure than bag mask ventilation. But I think it's really important to be aware of what your institution is capable of in terms of care provided, to know when to escalate as a matter of stabilization of your patient. And that's where it really comes down to that early assessment and being aware of some of the warning signs to maybe initiate a transfer if your institution doesn't have it. Really important to listen to your nurses. I listen to my nurses, and I feel like if somebody, do not be afraid to speak up. If you realize that in a resuscitation, you're not able to accurately measure the heart rate, for instance, your stethoscopes maybe are providing a hindrance, then advocate for getting those EKG leads and speak up and say, out of the last 10 resuscitation I went to, we only could hear heart rate half the time, or we struggled in that way. Because I really feel like, it's a team effort. And I think one of my, a word from one of my favorite attendings, he says, don't let me mess up. We are a team. And so if there's an equipment or a piece of equipment or something that you feel that your institution can utilize to optimize patient safety, then bring it up, speak up, and realize that your voice is valued. And if you're speaking to somebody who doesn't value your voice, find somebody who does.
Mm-hmm. Absolutely. I couldn't agree more. I know briefly you and I were talking about the role of nurse educators on units, and I'd love to ask on the same vein of how important you feel like it might be to be training staff members on not only the equipment that's available, but on also how to effectively take care of patients when you maybe don't have all the resources that you need. We know with COVID and all of the chaos that threw our way, that sometimes supply chain does get disrupted and you do have less resources than you would like at times, and what best practices there might be as far as training staff on a range of methods and resources.
Yeah, I think that's a great question. And I think we've all, had to adapt a little bit with the supply chain issues. And, there's always, I say there's emergent, urgent, important, et cetera, issues. And, when I've always worked at educational institution, and, it's kind of the saying, see one, do one, teach one. And I would say what that means is that you're relying on your team. So that nurse who maybe you don't have a nurse educator that you can call, but you've got a nurse who's been working at the institution longer. We have amazing position aids now. I think probably most everybody knows about them, the little swaddle, things. I remember when, a nurse taught me how you roll up a blanket and you can actually create a swaddle using rolled up blankets, around the head and around the feet to kind of create that womb-like environment. And I think knowing why it's important helps your own innovative ideas to figure things out. Um, I know with a nurse who created the design of the portholes for the giraffe isolettes, and it was a nurse who, you know, thought of what she needed to be able to do the care she needed in the shape, et cetera. And so I think, your own innovation and relying on the resources and your colleagues who maybe have more experience or have worked at other places to say, hey, what did you use in this instance? And as long as it's safe for the patient, worth trying out.
Absolutely. A couple conversations around our ET tube management. What do you think about the POCUS solution for ET tube verification of placement, the point of care ultrasounds that you can do at the bedside? There's been some studies about its use in NICU settings, and I'm curious if you've used it or if you have been familiar with that at all.
That is a great question. I'm actually not familiar with using it for endotracheal tubes. We do have a POCUS team, so I really appreciate this question because I will bring it to them. Um, I I think that a lot of ways to verify endotracheal tube placement that are non-invasive, meaning usually you get that initial chest X-ray, but you can tell by the feedback from the ventilator as far as your volume per kilo that you're getting of air, and you can tell the amount of leak around it, and you can um, you know utilize your blood gas values, etc. So that's a really great question. I'm not familiar with point of care for that purpose, but I would definitely bring it to our point of care team to see what's out there and if they're familiar with it.
Similarly, how do you know how common the near infrared spectrometer, the NIRS solution?
Yeah, so I think it's to some degree institution specific. It's very common in our NICU. We have a neuro NICU team. I'm part of that, and we actually have a top 13 diagnoses that we focus on for baby that would either get NIRS or AEG monitoring or both. And so, for instance, if a baby had a PDA, a patent ductus arteriosus, that baby would be on NIRS monitoring because that NIRS monitoring is a non-invasive way for us to identify a hemodynamically significant PDA rather than just repeat echoing. Additionally, a baby that's born under 29 weeks, we automatically put them on the NIRS monitoring for their first week of life. If they're critical or unstable, if they're having seizure, if their neurological exam changes, if they become more critical, then those will all be reasons that we would utilize that NIRS monitoring. Additionally, our hyperthermia patients, we would also use it. So I think if you have that ability and you have the monitors, it's a wonderful way to really get some important information and really support your ability to optimize their care and to maybe intervene or persuade you. Maybe you're debating giving a blood transfusion and your NIRS value is hovering around the 50%, that you then say, okay, this is actually an indication, even though my FiO2 requirement's not super high, but my cerebral NIRS value is hovering, and let me really optimize this baby's status.
Yeah, absolutely. We have a question about your experience with palliative care in the NICU and sort of the same idea of how we take care of patients well and appropriately with the different technology and resources that we have to best support their respiratory system and best secure that access. So I'd love to have you speak a little bit about what it's like having these varying solutions and trying to take care of patients in palliative care.
Yeah, I think I appreciate that question. I think our use of palliative care consults and invitation of the palliative care team to be a part of our team has really increased over the past few years. In my own experience, I think also the availability of that team and, staffing, I think applies to everywhere. But, we work in a field that has, some really difficult diagnoses. We work with babies that may not ever be able to go home in a safe manner. And I think it's really important to um, to bring in that palliative care team and to have those open discussions with family, that to really identify what the family's wishes are for their patients, what the family's desires are for their family dynamics. It's really easy to list out all the things that we can offer, but maybe that isn't in either the family's best interest, the patient's best interest, or in any way what they foresee as their future. I can say, okay, I'm going to, put a trach G-tube and get the baby ready to go home, and the family doesn't want a baby at home with it that's trach and G-tube and feeding tube dependent. So then it's to explore, why, if and when those things are offered, if that's not the outcome that family desires, because this is an unrecoverable situation for the baby. So, you have some really, really difficult situations. Additionally, you might have a family that, maybe had a profound neurological insult from a very, terrible situation, and they don't care. They say, my goal is to have my baby home and to have my child home, and to recognize that for that family, even if they only have 5 or 10 or 15 years, that's what matters to them. And it's our goal to work with the families, and palliative care, I think, is a key component to elevating those conversations in a safe space so that everybody can be on the same page.
Yeah, absolutely. There's nothing better than trying to help the family reach those goals. I did have one other quick question, a little bit more also about some of the equipment that's used. There's a question if you use or maybe even prefer iGels or LMAs for some of those advanced airway options.
Yeah, the LMA for sure what I'm more familiar with. I was not involved in the decision for the iGel versus the LMA. And so I will do more research about that because yeah, I think it really, it's a team effort as far as consistency and what you want to train your staff to utilize, and obviously the size, the discrepancy of which patients it would be appropriate for. So we just launched the non-invasive surfactant administration in December. So I myself have only been part of that team a few times, but I'm really, based on a lot of reading and a lot of research, I'm really excited to have that capability.
Absolutely. I do want to acknowledge we have some students who are joining us today. And so I would love to ask, what does it take to be a neonatal nurse practitioner? Do you have to love technology or the innovation of equipment and some of that? But if you want to speak a little bit to your experience of what that journey has been like.
Yeah, I actually went to nursing school to become a neonatal nurse practitioner, and I read about careers. I lost my dad when I was 15, and my mom was very much like, you need a job to support yourself when you get through school. And so I went to the Britannica, Encyclopedia Britannica, and read about careers. And they had a neonatal nurse clinician listed out, and it was blown away because I never even thought that was a possibility. And honestly, for me, I love being a NICU nurse. Like, I graduated my capstone in NICU, and I absolutely love being at the bedside. And I almost did not go back to school because I loved my patient population. I was there at the University of Kansas, and I loved my team and the collaboration and whatnot. And it was really my mom who encouraged me and said, she said, you can always work as a NICU nurse, but you're at an age that it's probably a good time to get that that degree now that you've got the opportunity. And I applied and got into graduate school right at the 2-year cusp. So the program that I went to required 2 years of NICU nursing experience in a level 3 or above in order to go to graduate school. I worked all the way through. And it was right when online learning was becoming a little bit more common. And I think that was to address the shortage of nurse practitioners in some of these specialties. I remember my professor telling me for each of us at graduating, there were 40 jobs available to us. And that again was a recognition on the fact that, this is such a wide open field, and it is such an exciting field where you can, treat many different demographics of patients, work with families. You have the little tiny micropreemie all the way up to the chronic lung babies that, look like they can walk out, but they're not walking yet. And honestly, I feel very privileged to work at a place like Stanford, that I feel like we can provide pretty much anything the baby needs, whether it's a baby born without kidney that needs to go on dialysis, upon birth, all the way to the little 22-weeker who is maybe only 300 or 400 grams. And it really is just a matter of recognizing that ability to be on that journey with the family, and to see them, too scared to touch their baby, get to the point where they can't wait to take their baby home. And yeah, I mean, I would say if you have any interest, go for it. It's a really, really great field. It can take you anywhere in the world. And I feel very, very lucky to absolutely love what I do.
Mm-hmm. Yeah, you don't see very many nurse, or at least in my experience, I think for many of us, you don't often see advanced nurses, nurse practitioners in the NICU setting. And to see that becoming more common is really wonderful, to get to see nurses expanding into those roles and being able to be a part of a lot of the care for patients that you do love to do as a NICU nurse, and getting to
we have,
people.
and I think something that's really great, or really where I again feel very lucky that within my group of nurse practitioners, that we actually have subspecialties within our group, where we have a nurse practitioner who is a neonatal nurse practitioner, but her focus is on our nephro NICU. So she is the go-to person on the advanced practice team to coordinate and work with and education, et cetera, and kind of own that nephro NICU program and work hand in hand with the nephro medical director. Additionally, we have a nurse practitioner who works hand in hand with our BPD clinic. We call it CRIB, so cardiorespiratory infants with BPD. And so she has a set amount of time that she helps run that clinic. She is that continuity of care where the patients know her on the inpatient side, and they continues to follow them on the outpatient side. I personally work very closely with our neurology team. So I'm part of the neuro NICU, and so I work very closely with one of my colleagues who's also a nurse practitioner. And so we have a team dedicated to our neuro NICU patients, and they're not like separate units, but just, like a unit within a unit. Additionally, I'm the ROP nurse practitioner consultant. So I work very closely with our ophthalmology team and ensure that all the babies that are at risk of developing retinopathy prematurity get screened, help with the screening times and medications and treatment modalities, and making sure they get plugged into the systems where they need to be. So I think it's really great even within our team to see, kind of that solid core of knowledge, because we do so many things and we expand in so many different areas, and then collaborate together to optimize that patient care, and be there for the family. So it's great.
It's Christine. I'm going to break in here. It's my opportunity to do some recognition. So I want to thank Rachel. Rachel is one of the nurse practitioners at Stanford Medicine Children's Health who speaks on our regularly scheduled education throughout the year. So again, when you get a chance, go look at MCPOP, mccpop.org. And we really are thrilled that we have these nurse practitioners to educate us and teach us.